Jim College of Ayurveda, Udupi, to take over the session. Welcome, sir.
In the last session, we had discussed about the pathology and the diagnosis of rheumatoid arthritis. The next part is about the management point of view. There is absolutely no definitive curative treatment for the rheumatoid arthritis, and all the management would be just to improve the general condition of the patient and to reduce the symptoms, ameliorate the symptoms. And the options of the treatment are many, and primarily in brief, these options, pharmacological interventions, the drugs which could be used are categorized as non-biological or biological disease-modifying anti-rheumatic drugs, which are now becoming popular. These days, it's one of the current fashion, like the disease modification drugs are one of the popular drugs now. And steroids, non-steroidal anti-inflammatory drugs, corticosteroids, analgesics are the commonly used drugs. Now, these disease-modifying anti-rheumatic drugs, which are now popular, again they are categorized into two categories: non-biological and biological. And non-biological are chemicals, biological from plant or animal origin. And among them, hydroxychloroquine (HCQ) is one of the very popular drug which is used almost in all by all rheumatologists. Then the other choices are like methotrexate, azathioprine, sulfasalazine, then leflunomide, cyclosporine, gold salts, D-penicillamine, minocycline. Biological are now, these are now becoming still very popular, and they are very costly. Biological are very costly, and as per the standard practice, the non-biological DMARD and biological DMARD should be used only after the trying the other drugs like methotrexate or hydroxychloroquine. These are the drugs, and they only when the patient doesn't respond to this treatment, then only it can be used. These biological or non-biological drugs are to be used. And but very interestingly, most of the rheumatologists in India, they start with the biological drugs in the beginning itself, which are quite costly, and these are etanercept, infliximab, and the new molecules are coming up now every day, and these are certain of the molecules which are used now. The other drugs which are used are NSAIDs, and among the NSAIDs, the earlier popular drug is ibuprofen. Ibuprofen was quite popular at one stage. Now, of course, it has lost its popularity. Naproxen, ketoprofen, and piroxicam. Then another group of the drugs which are again popular earlier are COX inhibitors, or COXIBs. But these days, COX2 inhibitors also have become less popular, considering that they are having more adverse effects. And but still, there are certain prescriptions where these drugs are still prescribed. But of course, the COX2 inhibitors now are almost obsolete now, uh, as such. And among them, the one drug which could be quite frequently used as a symptomatic treatment to reduce the symptoms could be diclofenac sodium, diclofenac, or ketorolac, naproxen. These are often used now to reduce the symptoms of severe conditions. Then non-pharmacological therapeutic modalities are the other popular treatment protocols which are used now in the contemporary medicine, and they could be splints which can reduce the pain and distress, improve the general functions of the body. Then other equipment which can help in improving the functions like assistive equipments, lots of them are there. Joint protection, education to the patient about how to manage with the deformities, exercise programs, hot packs, electric mittens now, which improve the which increase the blood circulation over the area, a hot shower, spas, ultrasonography, diathermy, so on. Lots of such options are available now, and the most common and adverse events of the drugs, the most of these drugs are quite toxic, and most of the times the patient would have more serious problem due to the drug treatment than really due to the rheumatoid pathology. And among them, the methotrexate and leflunomide, azathioprine, these are well known to produce liver and bone marrow toxicity. Cyclosporine, gold salts, D-penicillamine, they are known to produce the kidney toxicity. Methotrexate also is known to precipitate pneumonitis, and the patients with the lung involvement, methotrexate would worsen the condition. Allergic skin reactions also are quite common. Autoimmunity could be triggered with the depenicillamine and sulfasalazine and minocycline, etc. Patients who are on most of these anti-rheumatoid drugs, they are more prone to develop infections, particularly azathioprine and cyclosporine, that will be suppressing the immune reactions of the body, and hence there is no satisfactory improvement or satisfactory treatment from the contemporary science point of view, and most of the patients of rheumatoid arthritis would end up in Ayurvedic clinics or Ayurvedic hospitals everywhere. And when I treat the patients, my prescription would be based upon the considering that rheumatoid arthritis as a variety of Amavata. Of course, Amavata is not a single condition. It could be produced due to multiple causes, or it could be presented with the multiple presentations, and one of the presentation is that of rheumatoid arthritis, and the typical description of the Amavata or the source of the Amavata is the diet. Interestingly, that relationship of the diet with the rheumatoid arthritis is not clearly described in the contemporary science, but we can see it practically. The trend, as I told you in the previous session, the current trend is about the gut mucosa and gut environment related to the rheumatoid arthritis is becoming one of the major research subjects, but its clinical utility is not there. It is not used as such. That information about the status of the intestine and the relationship of the rheumatoid arthritis, that though it's now becoming known, clinical utility of that kind of information is not yet used. But from Ayurvedic point of view, that's very clearly mentioned in the Samhitas, like the cause for the Amavata is due to the dietary and lifestyle factors. Viruddhahara chestasya mandaknehi nishchalasya cha snigdham bhuktavado hennam vyayam akurvatastada वायुना प्रेरितो श्यामः श्लेष्मस्थानं प्रधावति तेन अत्यर्थं विदग्धोऽसौ धमनीः प्रतिपद्यते. There is two important factors. One, there is a collection of the toxic substance, toxic metabolic products which are due to improper metabolism, and that would be reaching to these different sites, that toxic substances reaching to the different sites through the vascular structure, and they may produce the lesions anywhere in the body, and they may produce the obstruction and leakage of the substances in the channels of the body. Srotamsi abhishyandeti nanavarno atipichilah janetyashi daurbulям gauravam sudasya cha. So it can produce involvement of any of the organs of the body, even the cardiac functions could be affected, and this ama is one of the issues. In the current trend, the oxidants which are described as such as the metabolic products, they are very close to the description of the ama, or any other toxic metabolic substance also can be considered as ama, and hence Amavata is not only rheumatoid arthritis. That has to be very clear. Amavata could be attributed to large number of disease conditions from the current point of view, and rheumatoid arthritis presentation fits well with that description of Amavata, and the principles of the treatment of Amavata can be benefit the patient, and particularly युगपत् कुपितौ अन्तः त्रिकसन्धिप्रवेशकौ स्तब्धं च कुरुते गात्रम् आमवातस्य उच्यते. The joint involvement due to these toxic substances, including the issue of autoantibodies or autoimmune pathology, are the Amavata. And when it comes to a question of management, from my point of view, I consider the Amavata, the rheumatoid pathology, in three categories particularly. The three categories, the one is where there could be kaphaja or the real kaphaja vyadhi lakshanas. Angamaddu, aruchihi, trishna, alasyam, gauravam, juraha, apakah, shunapangana, amavatasya lakshanam, which is usually seen in the initial stages of the rheumatoid pathology, where the patient would have low grade fever, the swelling in the joints, but not much of the degenerative pathology. The bones are not deformed, the early stages of rheumatoid arthritis. In that condition, my prescription would be Kaishara Mrithinjaya, as I consider this as the Kafaja like conditions. Then another category of the patients whom we see quite frequently would be patients who have a more inflammatory changes. The next, usually the grade type 2 type of, or type 2 to 3 or stage 2 to 3 of the rheumatoid pathology, where there would be more of erosion of the joints and more of inflammation, and even that extra articular involvement, synovitis, that kind of a stage which is presented with the Pitta Lakshanas. I would be prescribing them the Kaishara Mrithinjaya Manjistadikvat. In the later stages, when there could be the deformities, and of course that description would be Pitta Sadaharagam Sashulam Pavanangam Stimidam Gurukandum Cha Kapadustam Tamadisheta. So sorry, the shloka sequence is slightly up and down. The Kapaja shloka should be up, and the Pittaja shloka should be in the lower level. Okay, alright. Then in the severe conditions, when the patient would have a severe deformity as such, where there would be Sarujam Shotham Yatradosha Prabhide Sadesho Rujyate Atyartam Vyavidhi Vyavrishtikehi Jane Sah Agnitarbalam Prasai Karati Gauram Utsahanim Gauram Daham Bhumutatam Kuksho Katinaram Shulam Tata Nidra Vipariyam Trithardi Brahma Murchan Sahagam Vidbhatam. These are all the extra articular manifestations of the rheumatoid pathology or the gross deformities of the rheumatoid pathology. In that condition, the prescription would be Kaishara Mrithinjaya Amritarista or Ashwagandharista, depending upon the condition. In all the status, in all the conditions of the rheumatoid arthritis, Amapachana Chikitsa like Agni Chikitsa and Ksharabasti produces dramatic changes in the outcome. And as far as comparative results of the management of rheumatoid arthritis from the contemporary science point of view and Ayurvedic point of view, definitely Ayurvedic treatment would be much more beneficial and more economical, and patient compliance would be much better, and hence at present I would consider rheumatoid arthritis as a disease of Ayurvedic domain. If we are carefully select the patient and manage with the prescriptions, definitely yes, they can be managed much better. But there are certain conditions where there is a total difficulty to be treated, and the difficulty treat patients, and it's quite important to predict the outcome. Of course, the patients, even in the contemporary sense, they are categorized as difficult patients, and I would be categorizing these difficult patients as any patient who has a SDS score of more than 12, where the huge number of joints are involved and there is also a gross deformity. Our joints, they are fibrous, significantly deformed. Patients who have extraarticular manifestation like lung involvement. Patients who have other comorbidity like diabetes or other conditions, disease conditions. Juvenile rheumatoid arthritis, which occur at a younger age. These are difficult to be treated cases. In such conditions, along with the same prescription like Ashwara Mrithinjaya, I would be adding either Ashwagandharishta or Abhrakavasma Tapyadi and Avipatikar Mishrana, or maybe rarely Suvarna Basma. Rasayana Aushadhis are prescribed. And Virechana or Rajayapan Basti also can produce some changes in the outcome, but in these conditions the outcome would be poor. But still we can claim that this treatment protocol would be better acceptable than the contemporary management point of view from the for the patient. Hence, if we select the patients carefully and manage, it can be used as such. It can be much beneficial for the treatment. Now, there is to say, like to objectively show like which of the patient has really improved or not. There are many protocols which are used in the now those who are interested in research activity, documentation of the clear clinical outcome from that point of view, or those who are preparing for thesis work in rheumatoid arthritis, to measure the disease activity, there are many standard protocols which are used in the contemporary science, and among them the most important is the CRP, DAS28 CRP or DAS28 ESR criteria is more important, or simplified disease activity index is rather another simpler, easier options of the assessment of the treatment. So again, I am not going to the details of all of them, but I would be just referring to one of the standard, the frequently used one, and which is easy to do from the current point of view, is the Simplified Disease Activity Index for Rheumatoid Arthritis, or SDA. Now, I am referring to this from the point of view of those who intend to document and have a presentations or research activity related to rheumatoid arthritis. This index can be used as relatively simple, and the standard index, calculating the index would be SDA is equal to SJC is a swollen joint count, the total number of the swollen joints, and TJC is a tender joint count, and PGA is a patient global assessment of disease activity, like how the patient would assess about the disease activity, like whether he feels better today or compared to previous days. Then evaluator global assessment of the disease activity, the clinical assessment, like how a clinician would assess that, and then CRP level in milligram. In these are added together, that gives the index. And in general, if the disease activity index is more than 12, that condition would be having a poor outcome. Whereas, and from the clinical point of view, the standard now is if the response, you claim that the response, your therapy has responded to, or a patient is responding to the therapy or not, the count should be at least reduced by 7 points, and the outcome is considered to be excellent if it is decreased by 17 points as such. This is the standard now used, and very relatively simpler method of assessing the disease condition. Whereas the other protocols, of course, are there, but they are not really. I would not go into that detail. Those who are interested, they may go through that. But SDA is one of the easiest options, which can be maintained. Record can be maintained easily. Then the other complications of rheumatoid arthritis and its treatments, many times the patient would have more complication due to the treatment of rheumatoid arthritis, but you'll find many of the patients of rheumatoid arthritis coming to you primarily from a treatment management point of view. Many of the patients who come at that level where there could be systemic complications, and among those complications quite important are, one is Felty syndrome. Felty syndrome is a triad of rheumatoid arthritis, neutropenia, the total WBC count would be reduced, and splenomegaly. Now, WBC count being reduced is usually due to the immunosuppressive treatment given to the patients, and such patients are more prone to develop infective pathology. So, most of the patients would have multiple infective conditions. Management of that condition would be to make a standard prescription for Felty syndrome would be difficult, but I would say that the patient would have a high risk of recurrent infections. So you have to watch and wait for the clinical this presentation, and selective drugs could be used. But some of the along with the usual treatment protocol like Mrityunjaya, such patients would respond better when we add Makardhwaja to the prescription. And the Baker cysts, which are rough cyst-like swellings, particularly in the knee joint or elsewhere, they may rupture suddenly and they may produce an acute presentation, acute swelling in the joint, limbs with pain. Often they may produce a clinical confusion with the deep vein thrombosis. So, one of the important issues is a patient of rheumatoid arthritis. When the patient presents with the sudden onset of acute swelling in the limbs and producing somewhat simulating the clinical presentation of deep vein thrombosis, it's quite important that you go for the investigation and confirm whether it is deep vein thrombosis or not. A ruptured Baker cyst by itself doesn't require any specific treatment. The only thing is you will have to give rest to the patient for at least 1 or 2 weeks, and usually that edema subsides by about a week or so. And all that treatment will be the same as we treat in other conditions, rheumatoid arthritis, same Mrityunjaya. But I would be prescribing Punarna at that stage so that the patient's symptoms of swelling would be reduced. Even if you do not give the treatment and if the patient takes rest for about a week, usually the swelling subsides by itself. Another of the complications which can occur could be compression disorders. like carpal tunnel syndrome. Carpal tunnel syndrome is a compression of the radial nerve at the carpal tunnel, or similarly, nerve compression or what we call as the compartment syndromes can occur also as a complication of rheumatoid arthritis, and because of the deformities of the joint as well as the inflammatory accumulation. These do not respond easily. The outcome would be poor. Even with the surgical treatment in carpal tunnel syndrome produced rheumatoid arthritis, the outcome is extremely poor. From Ayurvedic point of view, again, my management would be there is no question of any specific other treatment protocol. The same treatment protocol which I have already suggested would be used, but Punarva Mandura added Shothagna treatment would be helping somewhat better in the outcome, but again, these results would be comparatively poor. A carpal tunnel syndrome produced due to non-rheumatic origin that improves much better than really the rheumatoid pathology induced carpal tunnel syndrome. Then the other complications are majority of the patients of rheumatoid arthritis would have depression, and it is claimed that up to about 40% of the patients develop depression, and that's due to the continuous pain and the deformity which is presented. So they may require a antidepressant treatment, and say patients who have a marked depression, I would be prescribing Smriti Sagar Rasa along with the same protocol. Then the infection, as I told you repeatedly, the patients are more prone to infection, particularly if the patients are on immunosuppressant drugs. So patients who are on immunosuppressant drugs, if they can be withdrawn, they can be managed, and I don't suggest any specific treatment for the infection. It has to be case specific. You have to assess the condition and then treat the condition. Most of the presentation, the infections could be either it could be respiratory infections where the patient would have repeated respiratory infections, or cutaneous manifestations where there could be multiple ulcers, or maybe the pus collections, pus pockets formed, abscesses. These could be the presentation of the infection complication of the rheumatoid arthritis. Even malignancies like lymphoma, lung cancer, skin cancer also are known to be a complication of the rheumatoid arthritis when the patient has pathology for a quite a long time. Of course, there is no specific curative treatment for that. The treatment would be as per the current protocol, and the prevalence of other chronic conditions, particularly the disease conditions like patients having low backache, mental behavior conditions, then heat stroke like heart pathology, stroke and cardiac pathology, asthma, osteoporosis, diabetes, COPD, cancer, kidney diseases. These are certain of the very commonly coexisting conditions with the rheumatoid arthritis. As per the standard study done elsewhere in Australia, of course, this study is from Australia, people presented with the conditions like back pain in the back, low back area, larger number would be having rheumatoid arthritis. Now, the issue is a patient presenting with these mental conditions, the incidence of rheumatoid arthritis as the triggering factor, they are quite huge. Or patients with the cardiac pathologies, vascular disorders, that coexisting rheumatoid arthritis conditions are quite frequent. So, the important issue, the main purpose of presenting this would be the comorbid conditions in case of rheumatoid arthritis, which make the clinical presentation more complicated. Patients may present to you with these the primary symptoms like the kidney disease, osteoporosis, etc. There could be an underlying rheumatoid pathology which either is diagnosed and treated, or maybe might not be diagnosed, and hence from the clinical point of view, patients presenting with these chronic disease conditions, you always have to keep in mind that there could be a underlying pathology of rheumatoid origin which has to be identified clearly and managed. That's all the point from the point of view. Life expectancy of patient of rheumatoid arthritis is comparatively lesser. The number of patients, again based upon the study rheumatoid arthritis and the other conditions, the life expectancy is comparatively lesser, and it gets reduced if there are more of the total other coexisting complications like diabetes. Diabetes patients and rheumatoid arthritis, the life expectancy is much lesser than the average. Surgical procedures also often suggested, recommended in the rheumatoid arthritis, particularly when there is a gross deformity, and the surgical options could be synovectomy or along with the tendon and synovial membrane, tenosynovectomy, tendon realignment, reconstructive surgeries, or arthrodesis, completely fixing the joint so that there will be no movement. But none of the surgical treatment would produce give you an excellent result or excellent functional improvement. Marginal functional improvement could be there, but symptoms of pain can be managed to a great extent with the surgical treatment. And outcome of the surgery is poor, not very popular. Only in extreme severe conditions surgery could be recommended, and that's about the rheumatoid arthritis. So we will conclude about the rheumatoid arthritis as such. The next condition which we refer to would be with among the Mamsa or Mamsa medo or connective tissue disorder is a systemic lupus erythematosus or SLe, and I refer to these conditions in priority because rheumatoid arthritis is more common among Ayurvedic treatment protocols. SLE also now is becoming quite common among the patients whom we see. So, based upon the number of patients, I have selected these disease conditions. And SLE or systemic lupus erythematosus is a disease condition where the exact etiology is still not known. So, there are a lot of theories about it. And the more popular theory about SLE is considered to be it's an autoimmune disorder, and autoimmune pathology where the immune factor is against the antibodies of cytoplasmic structure, cytoplasm, and it presents with the multi-system inflammation, involvement of the different systems of the body, and having a variant, highly variant clinical manifestation. It's not a single manifestation of SLE, and it tends to have a course of relapsing and remitting. So it's waxing and waning of the symptoms are common in SLE, and hence the exact diagnosis of SLE and to predict about the outcome of SLE is quite difficult. And the causes of this SLE are again huge. It could be genetic, epigenetic, like which has to affect the genes in the later part of life, even ethnic, like certain groups of people, they are more prone to they have the SLE. It could be due to triggering of some factors which affect the immune system, like the vaccines given, hormonal factors, environment factors, etc. And often, as per the data, 90% of the SLE are seen in women. The general theory about again popular theory, again this theory has a certain of the exceptions. The general theory about the systemic lupus erythematosus is there is a innate susceptibility due to the presence of abnormal genes, and the abnormal genes now are identified as a HLA type DR32 type of these genes are identified, or they are also considered as other immunoregulatory genes, or at the hormonal levels genes could be affected. That is an epigenetic factor which has a basic tendency in a large number of people. But these persons who have these HLA type genes may not develop the pathology, clinical presentation, unless there is some stimuli. The stimuli, again, the very popular, commonly known stimuli which trigger the SLE are exposure to ultraviolet light, or some of the infective pathology, acute infective pathology, microbia present in the body, or drugs, very frequently used drugs. Even diet, food also could be one of the triggering factors, which results in proliferation of the beta cells and the T cells in the body. They tend to get activated, and the lymphocytic mechanism, lymphatic mechanism would be triggered initially as a proper immune response, but that immune response misses the track, becomes against the body. See, ideally the immune response will be producing antibodies against the foreign organism or the toxic substance or the molecule which affects the body would be neutralized by the antibody. But later on it misses that path and it results in the possibility of development of the antibodies against the cell protein where that it fails to identify the self. So self recognition would be affected and that results in autoantibody productions, and that's how the SLE is triggered. That's about the known pathology. Again, with the known pathologies again, are known factors of SLE. As I told you, the exact cause for the SLE is still not known, but based upon the statistical incidences and the known pathologies, genetics now is given a lot of importance in the pathology of SLE. About 100 SLE susceptibility genetic loci are identified now, and mostly in European and Asian populations, which explains around 30% of the inheritability of lupus, but not all 100%. In 30% of the patients, the gene abnormality is identified, but still it's not in case of or to that level where therapeutic utility of this information is used. Then triggering with infections, among them Epstein-Barr virus infections, viral infections, which can present with the acute viremia, fever-like conditions, or retroviruses. They are known to trigger the SLE in patients as such. And pregnancy is one of the factors which is known. The pregnancy can even produce a flare up of the lesion, or it suggests that it's now known that the a flare up of patient the symptoms in pregnancy are rather much better. It can improve the conditions of the patient. So there is a bit of controversy, but in pregnancy, SLE produces more complications. That's all the issue from the point of view. So pregnancy is known to be one of the factors which can trigger in the SLE. Then other potential known factors which are again having some statistical relationship but not yet proved and controversial issues are like the silica dust exposure. Those who work in dusty conditions, they are again more prone to develop SLE. Cigarette smoking increases risk of developing SLE. Cigarette smoking is associated with the sudden development of the symptoms. High risk flares in the same sudden development symptoms, particularly cutaneous skin reactions, and the outcome would be poor, including chronic kidney disease, cardiovascular diseases also can be triggered in lupus patients who smoke cigarette. Now, whether cigarette smoking is to be considered as a cause of SLE or whether it is only a triggering factor is the issue of controversy. Anyway, patients who smoke cigarettes, they have a high risk of developing complications of SLE as such. So that's all the point. Then estrogen use in postmenopausal women also increases the risk of developing SLE. Now, estrogen often used in postmenopausal women to improve the general condition or to avoid that menopausal syndrome symptoms, but it has increased the risk. Now, statistically it's known that it increases the risk of developing SLE. Then patients who have photosensitivity, exposure to the sunlight, ultraviolet light particularly, the theory is that ultraviolet light stimulates the keratinocytes, which leads to overexpression of the nuclear ribonuclear protein and other cell surfaces. So that exposure to the extreme sunlight, ultraviolet light, triggers the cytokines, and then that would be producing the SLE as such. Breastfeeding is associated with the decreased risk of developing SLE. These are all the simply statistical informations. The exact cause effect factors are not known. So, but they have a value. I am not saying that they do not have a value, but that's not proved as such. The other again statistical issues are children who are having low birth weight or preterm birth weight, preterm births, like where birth occurs at earlier stage of more than 1 month prior to that, to the complete period, or child exposure to agricultural pesticides. Children who are exposed to these pesticides, agricultural pesticides, they have a high risk of developing early life SLE occurring in a young age. Pediatric SLE is another of the issue as such. SLE incidence also has a global distribution. Incidence is quite high in the eastern countries, but compared to Japan and China, India has a comparatively lesser incidence as such. But Asian people have a high risk of complication of kidney involvement and cardiovascular involvement in SLE, leading to a high incidence of cause of death. The global incidence has been estimated as 5.14 per 1 lakh person years, and in women it's 8.82. The incidence is quite comparatively higher. So globally, the incidence of SLE is quite wide varying as such throughout the globe. India comes in where the incidence is comparatively high, moderate, but not very high as such. The clinical presentation of SLE, as I told you earlier also, is quite widespread conditions, and hence the clinical assessment will be quite difficult. And the usual, the commonest, the most common clinical symptoms are considered as the major three sets, the triad of symptoms like fever, joint pain, and rash, particularly rashes, the skin rashes developing in childbearing age women. The other symptoms of SLE, they are categorized into constitutional, musculoskeletal, dermatological, renal, neuropsychiatric, pulmonary, gastrointestinal, cardiac, or hematologic. The patients of SLE may have any of these presentations or all of these presentations. That assesses the severity of the disease. Constitutional symptoms like simple fatigue, fever, pain in the joints, weight, sudden changes in weight. Musculoskeletal symptoms like arthralgia, where the pain again in the joints, arthropathy, where there could be joint abnormalment which can present with the deformed joints, myalgia, frank arthritis, avascular necrosis also could be the presentations of SLE. Dermatological presentations are characteristic like the malar rash, photosensitivity, discoid lupus. Renal involvement may present with acute or chronic kidney failure or acute nephritic diseases. Neuropsychiatric conditions like seizures and psychosis could also be the symptoms in case of SLE. Pulmonary symptoms of pleural effusion, pneumonitis, pulmonary hypertension, interstitial lung disease could be the presentation of SLE. Gastrointestinal symptoms like nausea, dyspepsia, abdominal pain also could be the presentation of SLE. Cardiac pathology like pericarditis or myocarditis also could be the presentation of SLE. And hematological conditions, cytopenias, leukopenia, lymphopenia also could be the presentation of SLE. And because of these reasons, the diagnosis of SLE becomes difficult. In children, childhood SLE, the common presentations are again malar rashes. Like malar rash, I will show you the picture. Like it will be very classical, which is a very classical presentation. And once you see the malar rash, the diagnosis could be comparatively easier. Then ulcers, which involve the skin as well as the oral cavity, the mucous membrane. Kidney involvement presenting in proteinuria or urinary cellular cause. Seizures, thrombocytopenia, hemolytic anemia, fever, lymphadenopathy could be the presentation in children. So patients, pediatric patients presenting with these symptoms, you will have to keep SLE as one of the possible differential diagnoses. So a thorough workout is necessary. Now laboratory tests that may be used for the diagnosis of SLE, again the one which is considered to be very reliable is ANA. ANA is considered to be one of the very reliable mode of diagnosis. 95% of the patients are sensitive, whereas all the other investigations, they just to help in prediction of the possibility as such. And the commonest simple investigations which can be used for predicting the outcome would be complete blood cell count with the differential counts, creatinine, serum creatinine, to rule out the renal involvement, urine analysis, erythrocyte sedimentation rate or CRP, which can help in predicting the disease level or activity. Then there are many complement levels, liver function tests, creatine kinase assay, which is seen in case of muscular pathologies, spot protein or spot creatine ratio, which also can help in identification of the renal involvement. So these investigations could be helpful in making the assessment of the clinical condition. Presently, there are new methods of investigations which are coming up to identify SLE, and these anti-dsDNA, anti-SM sensitive, and anti-SSA, anti-ribosomal P, anti-cardiolipin, or lupus anticoagulant, or antihistone. These are now coming up, and these investigations are quite costly investigations, and it may not be available in all laboratories. Um, Anti-dsDNA is now becoming more popular, and it's considered to be 70% sensitive. Then anti-ribosomal P predicts the risk of CNS involvement. Anti-cardiolipin predicts the risk of cardiac involvement. Lupus anticoagulant will be predicting the hematological risk prediction, and antihistone is common as a drug-induced SLE. But these protocols are not in regular use, so we may not use these protocols regularly in clinical practice, but only in very high sophisticated centers these facilities are available. So from our point of view, ANA is one of the most reliable method of investigation for SLE. The severity of the SLE and has to be assessed, and there are lots of different sorts of protocols used for predicting the severity of the SLE or even the possibility of SLE. It's also used as a classification, and the rather latest and quite relatively simpler method of assessing this, again because there are many methods, I would be referring to EULAR and ACR, European League Against Rheumatism, and ACR, American College of Rheumatology. They have published a new criteria of classification in 2019, which is relatively simpler and relatively maybe more useful, statistically stable like predictions, and this could be used for prediction as such. Systemic history like fever repeatedly, the score will be 2. Hematological findings like either leukopenia, thrombocytopenia, or autoimmune hemolysis, the score will be 3 or 4 as such. Neuropsychiatric symptoms like delirium, psychosis, seizures, the score will be 2, 3, 5. Mucocutaneous symptoms like where the patient may have a non-scarring alopecia, spots of hair loss. I will show you certain of these images also. Oral ulcers are very characteristic, wide ulcers which are characteristic. Subacute discoid lupus or acute cutaneous lupus, the skin lesions, I will show you the images of these later. And they also would be having the score of 2 to 4, 6 as such. Serocell like pleural effusion or pericarditis, the score will be 5 or 6. Then muscular cutaneous, where the patient have a joint involvement, the score will be 6. Renal proteinuria, kidney biopsy, again kidney biopsy may be showing the changes as class 1 and class 2. Class 2 would have the highest number of productions. Immunological domains like antiphospholipids, if they are identified, like anti-cardiolipin antibodies or anti-beta 2 antibodies or lupus anticoagulant, the score will be 2. Complement proteins of C3 or C4, the score will be either 3 or 4. When one is present, it is when is low, it is 3. When both are reduced, it is 4. Then SLE specific antibodies like anti-DNA antibody or anti-SNP antibodies, the score will be 6. Now the rule is a criteria should not be counted if there is more likely explanation for it than SLE. If you find other reasons for the symptoms of fever or so on, other than SLE, then that should not be considered. Then occurrence of a criteria on at least one occasion is sufficient, need not be constantly present. If you have seen any of these findings at one occasion, then that score has to be added in. Criteria need not occur simultaneously. There is no need to have these symptoms simultaneously. With each domain, only the highest weighted criterion is counted towards the total score. These are the guidelines to identify like whether the patient is having SLE or not, and based upon that, SLE is classified, the severity of the disease is classified. Certain of the images which explain these symptoms. Malar rash is classically also known as butterfly rash, which is often seen as symmetrical rashes more frequently on the face. Then photosensitive lupus erythematosus, systemic lupus erythematosus, where the patient may have that reddish spots over the exposed part of the body. This also is very classical, and the diagnosis of SLE would be comparatively much easier when you see these visible signs. Discoid SLE is another of the usual clinical presentation, which can present with the either scarification or without scarification. In the initial stages, it will be reddish or maybe blackish spot. Then later it becomes scarified as such. So any of these presentations could be the presentation of SLE. Then non-scarified alopecia or non-scarified alopecia is a characteristic. The spotty alopecia could be presented in many other tinea conditions, but in the tinea condition there will be no scar changes, whereas here you will see that in tinea there will be scar changes. In this condition there will be no scar as such, and the skin surface at the spot of that alopecia would be having some roughness. The incidence of alopecia or pattern of the alopecia could be of different types in SLE. Mild diffuse alopecia throughout the skull would be around 43%, and severe diffuse alopecia 15.6%, patchy alopecia as you see in 28.1%, and the patients having a lupus hair. Lupus hair is very characteristic, very thin, brittle, and curved hairs also could be the clinical signs. Oral ulcers of SLE also are quite characteristic. They are wide and comparatively deep and severely inflamed. They may present in the oral cavity, and they do not respond to the usual treatment of the mouth ulcers. That is the clinical presentation of SLE. Subcutaneous or subacute or cutaneous lupus is an acute condition. There will be severe erythema, simply not rash. There could be erythematous reactions which are sudden onset, rapidly developing, or when it is subacute, they may resemble the tinea-like condition. There could be circumferential lesion, but unlike that of the tinea, there is no central clearance. In tinea disease condition, the central area would be having a normal tissue, whereas in cutaneous lupus, the central area also would have the eruptions as such. That would be the presentation of SLE. Confirmation of the SLE or facilitation of the SLE diagnosis with the radiology is another of the issue. So, which we will continue in the next session. So, next session we will take up the radiology in SLE and continue further, and we will wind up today. If there are any questions, no. Right, there are no questions, we will wind up.